Thank you. So at 10:03, I'll call the Prescription Drug Affordability Board for May 23rd officially open. And at this point in time, I'd like to promote Senator Roosevelt from an alternate to a full board member for voting. In saying that, I'll go around and also introduce ourselves. My name is Gary Merchant, Representative Merchant, Chair of the Prescription Drug Affordability Board, and on the screen I have two. Representative Marsh.
Good morning, Gary. I'm Representative Marsh. I'm an alternate on the board and I'm remote because I've had COVID in my family, although I remain negative. And we decided that was the most prudent thing to do.
Thank you. Mr. Barry.
Good morning, everybody. I'm Rob Berry. I'm the liaison between the department and the Prescription Drug Affordability Board, and I am remote because I have COVID at the moment, although I am fairly non-symptomatic. So, but it's better to be here than with you guys at this point.
Thank you for that. And in the room we have Senator Roosevelt.
Yes, Cindy Rosenwald, Senate District 13, Nashua.
Tom Sherman, Senate District 24.
Thank you. So for the agenda review for today, I have on the schedule is the legislative update. If you still okay to do that, Senator Sherman, Senator Representative Marsh, new drug, and trying to determine what's considered a new drug and when. Update on the rules. We have Andrew coming down around 10:30 to talk about some data he was able to pull out of the all-payer data claim. The insurance presentation will be done at 11 o'clock. If we need to take a break with the AG's office, I don't believe that's going to be necessary. Is that going to be true? Thank you.
Yep.
Then public comments and we will adjourn.
I have to leave at 11:30, but I can call back in. Okay.
So in saying that, I'd like to have a motion on the floor. If people had a chance to review the minutes of the April 25th meeting.
So moved.
Thank you. Although at the roll call, we have people on the Zoom. So all those in favor, Representative Marsh? Okay.
Yes, I vote yes.
I vote yes.
Yes.
Yes. Passes. Regards to legislative updates, Senator Sherman and Representative Marsh, if you want to give us an update on SB 450.
Well, the most exciting, I'm going to let Representative Marsh tell the story because we cleared it out of the Senate. And
Yeah, EDNA recommended sending Senate Bill 450 to interim study, and we got ourselves organized, and AARP got very involved. We contacted a lot of people. We managed to flip it on the House floor and pass the bill as it came out of the Senate. So we ended up passing what the committee wants. The only thing going forward is the original House bill is up for an interim study meeting on Tuesday. And I'm going to push that the committee decide that no further legislation is necessary because we passed Senate Bill 450, but it doesn't really matter what they decide because the next legislature can do whatever they want anyway.
That's all good news.
great.
So can I ask? a question?
Yes, please.
So it was passed by the House without amendment
Right. So, it's,
on to the governor?
Yeah.
and I don't know, ARP here, is anybody here? We just need to make sure they talk to the governor's office.
Okay. Get him to sign it.
Because, yeah, you make sure he signs it because, you know, he was supportive of PDAB in the first place, but I wouldn't assume anything. So I would reach out to AARP and make sure they have contact with the governor's office. Probably better if I'm not involved.
It's probably better if I'm not involved either.
I'll take that as on my to-do list.
For me.
Yes. That's all good work. So in saying that, moving on to the agenda, if I can find my agenda.
Can we just ask for an update on where we are with fiscal?
Yes, that's on.
Oh, I thought that was part of the update.
Oh, no, okay, fiscal. That was part of the update. The fiscal, I did speak to Chairman Umberger. Her recommendation is continue with our request and not to take it off the table until we get the rules through. And that's kind of what she recommends that we do, even though the bill may get signed into law, which we'll do. You know, the bill, which becomes law, does have the non-lapsing account in it. She still recommends moving forward with the request.
But so we fiscal met on Friday and it was not removed from the table and so it had no discussion. And
So-
we'll just sit there.
Sit there.
Ask a question. Do you think it will strengthen our case if it's actually signed by the governor and in statute?
Yeah, I think so. I mean, and really until the end of, well, the last fiscal meeting will probably be, I don't know if we'll have one in December. But with this legislature, for sure November, as long as we connect on it by that meeting. We can just act on it. Otherwise, I believe things expire with the legislature. This fiscal will be reconvened in January.
But we should have, we should have rules in
Mhm.
place. We will have the new statute, the update in place.
Right, we should
presumably.
be fine. And I thought our expectation was around, well, there won't be a fiscal meeting in August. And I don't think we'll be ready in July.
No.
So probably the September meeting,
That's what
we'll
I'm
want
getting at,
to,
was just a timeline.
make sure we're ready and remove it from the table.
So there's no meeting in August, right?
No, there will not be a meeting in August unless there's an emergency meeting. We generally meet once in the summer.
Okay.
And it's scheduled for later in July.
Well, thank you for that. Result. In regards to the new drug reporting, I did get a question. I said I'd bring it to the board for an interpretation, how we want to interpret something. And the question was this. If a company buys another company or buys a product from another company and then puts their new label on it. So in essence, if you buy product A from company A and you bring it back into your portfolio and you relabel it with another name and probably another NDC number, does that constitute considered a new drug or is that just a relabeled old drug? And what they're trying to get to is that if you have a price point that gets beyond the Medicare specialty price, you have to then report it to the board. So the product is currently in the market. It gets acquired by another company. They bring it to their portfolio, they relabel it, put another name on it, put another NDC number on it, which is the identifier for the product. Do we consider that to be a new drug?
My gut feeling is the role, what we're trying to capture is the cost of drugs. So if it's the same drug, but by buying the company, relabeling it, and then reintroducing it, they're going to reintroduce it at a much higher price point, then we are starting at a new zero, or we're starting at a much higher price point. And I'd rather capture the difference in the price points and call it the same drug. That difference is what we need to be monitoring and why, and that's the kind of thing that
I would agree.
I'm
I
not
mean,
sure.
if
if
there's
I'm-
only difference is who the owner is.
Yeah,
I don't see that as a new drug.
It wouldn't be per se a new drug to the market, but when the new company relabels it and rebrands it, if you will, they may increase the price because as part of the acquisition cost to get back their investment.
but that we want to capture that delta. I mean, it's not that the board really can do anything punitive or otherwise. It's just we don't want to miss that information point, which we would miss if we then started it as a new drug.
To that effect, Gary, one issue that's been the case in recent years is when formerly generic drugs become brand name drugs, they
Mhm.
frequently get brought back to the market at much higher price points. So I think that we ought to consider them new drugs just so that we get the data.
But yeah, but Bill, if we consider them new drugs, then we don't get the delta between their old cost and the new cost, which is really what we're trying to understand, right?
That is what we're trying to understand, but don't we require the new drugs to give us data? Or am I misremembering the text of the bill?
We require a new drug if it goes beyond the Medicare specialty price point. Then they have to report it to the board. Otherwise, it's only at the end of the year, once a year, when they do their filing and price increases over time.
Okay,
So maybe,
So, and this
then
is
it's
a
a
game.
data I don't understand well enough.
It's one of those things I've seen happen in the pharmaceutical space. What will happen is, to get around the issue of having a price increase, another company, sometimes it could be even a sibling of the company, buys the product, rebrands it, and at that point in time, creates a new, as Senator Sherman said, a new price point. So then the price escalation, instead of being at $100, now is going to be based on $200. So
Okay.
we lose that delta between the 100 and 200 because when it gets repriced, it's like when you buy a stock, it's the same thing, you reprice it at that point. And I think we lose the history of the drug because in March, it was $100 that get bought in July and went to $200. All of a sudden, at the end of the year, we're at $220 was only 10% increase, which is still not within the requirements of the statute, but it actually went from 100 to 220.
I hear your point. That does make sense to me, Gary.
so I think the point that Bill is making and that I'm making are kind of the same. How are we capturing each of these? So if we kept it as based on the drug, the actual formula, or then they are reporting as part of their annual standard reporting if there's a price increase, right?
Correct, but the price increase would be based upon when they brought it back to the market with their name on it versus what it was when they acquired it.
Right, but we would still capture it within that 1 year period.
Yep. Because the company's requirement, you're only going to report to the board on drugs you own. So if you divested a drug, you would not report it.
Right, but the new company would have to report it.
It would, but it'd be based upon the $200, not the $100. So in other words, I have something, Arctic A, right, okay, and right now I've got it in the market for 100.
Right.
I sell it to Senator Sherman. So now you own the product. That $100 goes away because it's going to be now based upon what you want to do with the product.
Right, and that's if it's considered a new product.
If it's a new product, when it comes into the marketplace, there's no previous price.
What we want to capture, what I'm getting at is we want to capture the previous price and then this new markup.
Correct. So
So would that, if it stays as the original drug
Mhm.
and there's a new markup, won't that be reported in our annual?
because what's going to be reported is if you buy the drug, your reporting requirements is based upon the time you priced it and what your price point is from that point to the end of the year, not what you had in the market at a previous price point because it's no longer your product. So we lose that delta, which is going to be concerning because if you have
Well,
somebody,
Okay, so what I'm getting at is I don't want to lose the delta.
yeah.
So whatever we need to do to make sure we're not losing the delta is what I would like to see us do.
So we may have to go back in the rules and say when you do reporting is that during the 12 months, if you bought a product and relabeled it, what was the price point before you acquired it? I think it's what they're trying to get to, right?
Right, exactly. So we should go back and.
I mean, so when you get through public comments, when we do this, is when to change and modify the rules based upon that. So when they
Right.
bring a new product, is that okay? you've reported something back in the reporting requirements, I think, so Chairman, is that what was the price point before you acquired it? Makes sense?
Yep.
Okay.
Is everybody in agreement?
Are
with
we all in
that?
agreement with this?
Yes, I think we want to capture
We want to capture it, is
the
what we
whole
care about.
price history.
Price, exactly. Regardless of the ownership. All right. And Attorney Barry, do you want to give us an update on the rules where we are now? That's the point. Okay. In that case, I call you up on the price points that
Would it be easier? I just like, I came down because I was here, but it would be easier for Nancy to
Pull it up.
do it
Pull it up.
remotely.
You
or
can sit
Can you
next
just
to
pull
me.
it up?
so right. Please join us on the hot seat.
Oh,
I
Rob
see
is back.
somebody else.
Oh, Rob's there?
Yes.
Okay, Rob's back.
There's someone else on the Zoom. who's
Yeah,
trying.
he's the, he's going to present at 11 o'clock.
Oh,
Thank you.
okay.
Thank you. Let me know. So Attorney Barry, do you want to give us an update on the rules?
Sure. So we submitted the fiscal impact statement request to the LBA late April. We received the actual fiscal impact statement back maybe a week or two ago at this point. So we are on track to have our public hearing for June 16th for our initial proposal. From there, we will receive public comments and we will consider those. And then at which point, probably sometime in probably more likely sometime in July, we'll file our final proposal with GELCAR and be on track to have the GELCAR hearing in August. So if all goes according to plan, then we may have our rules adopted by August.
And you make sure that you talk to Attorney Barry about what we just talked about.
For the rules that we change once you get to public comments.
Okay.
So we'll-
Yes. Go ahead, sorry.
So see, right now on June 16th, we need to also remember to post that in the general court calendars.
Mhm.
So we need to be sure that it gets posted.
Okay.
On June 16th, I believe the only requirement is I will be there along with yourself.
Yeah,
And-
I will be there. Allison will be there, and it'll be probably right in that room you're in right now, where we'll have a opportunity to take public comment.
And the public comment at this point in time will be in person. It won't be done via Zoom.
Last I knew, we were still doing a Zoom component. I don't know if that's changed, but I believe it's still a possibility to do a Zoom component for public comment.
And then at that point in time, there's still time after June 16th for written comments to be submitted.
There is, I think it's another 10 days, I think, 10 business days, I think. I'd have to double check the statute. I mean, I was not prepared to work from home today, unfortunately, so I don't have everything with me that I usually have, but I believe it's another 10 days.
And then once that's done, what will happen is we'll take all the public comments, look at any revisions to the rules to make the final version of the rules, correct?
Yes, we can do that, and we can also update the rules at that point to reflect legislative changes as well.
And those would go to GELCAR. Now GELCAR, does anyone know whether GELCAR is going to meet in August?
Yes, they will be meeting in August, I think.
They will.
Yeah, their schedule's already out, and they should be meeting in August.
So the goal is to again stay on track for the August 18th meeting of GELCAR.
That's correct.
And we have another meeting of this board, which is, I think, on July 25th. To review, sign off on any changes.
Yeah, we can do that then at that point.
And then we have fiscal, which doesn't, they just want the rules done before their September meeting. So that sounds like a good time.
When is that meeting?
July 25th.
What time?
I believe it was 10 o'clock. 10 to noon. So at that point, Senator Rosenwald work on with Attorney Fahey and Attorney Berry and Allison to look at any kind of revisions to set to the statute changes, public comments, incorporate all of that into the final version of the rules, which will then go to Chelsea. Is that correct, Mr. Berry?
That is correct. Yes.
So we're staying on track. And also I had a chance, thank you, Mr. Berry, for that, to work with Alma?
Yeah.
Okay, thank you. You want to come up? He was able to pull some data out of the all payer data claim base or something like that. He was the, did you want to go over some of the numbers? Do you have a copy of what's there? You want to
Yeah.
put up?
Yeah, Nancy is gonna bring it up. And I actually have Mary Fields here too, who did the real number pulling and the grunt work on this.
Thank you.
She manages that project for the department. So thank you for having us do this. I mean, it's actually an interesting piece of work that I think has never been done before. Maybe in the distant past, a few like this has been taken, but it's a really good use of the data set, obviously. And just since we have a schedule, right? But we've been collecting this commercial insurance data through state statute since 2005, as some of you may know. And you know, I came earlier to the prior meeting to present about the data. And this is sort of we expanded to look at the commercial data, but also the Medicaid data. And we have some Medicare Part D data, you know, partly out of a result of what the statute called for in terms of a data review. And this is really the only source, I think, right now, kind of comprehensive source of pharmacy data for the state. The tables which you got in your packet are from fiscal year 21. And the laborious part of this work is how like the drugs have to be rolled up to give a good honest view. So different dosage levels, different obviously brand versus generic, all of those things are rolled up to a kind of similar chemical. If you want this on the specific NDC level, we can do that too, but the NDCs change, as you all know, NDCs change all the time. So it's hard to keep track of this. You know, there are products out there to group drugs into therapeutic classes, but this assignment wasn't about therapeutic classes, but that may be another interesting way to look at this, to look at mood stabilizers as a class, that kind of thing, and the costs associated there. So on the commercial side, we do have gaps in this data. So the data really isn't the dollar amounts and total service counts. You shouldn't think of as being the total universe of costs in New Hampshire. That's very important. And that's why at the top of the chart, top of the presentation, we give how many people we're representing. So, you know, we have 564,000 commercial members in the data, and there's more than that in the state. So those can maybe be used to help adjust in your mind what the totals might be. We think the data is pretty representative. It's been used by the state and researchers for quite a long time, but it's not the total picture. So we don't have, for instance, out-of-state insurance. We don't have small plans. We're missing some self-funded plans. We do have all the state municipal employee data is in here. So a lot of the self-funded data is certainly still in the data. So the other thing I think that's worth knowing about these tables is when we're on the commercial side, and I think we talked about this the last time, we have what the plan paid to pharmacy, so literal kind of fee for service amount. And we have what the plan thinks that the patient owed. So which is a combination of maybe it's deductible, maybe it's a copayment. So it'd be whatever they have just loaded into their system. So it doesn't account for what the actual cash that changed hands with the patient. So if the patient had some kind of discount card or something because they had a high deductible, that would be blind to that. And then, of course, on the overall kind of payment side, we have no information about any arrangements the PDMs have with drug companies. So we don't have rebate arrangements or any of that in the data. So it's sort of like the kind of transactions that are happening at the time of the point of sale. So with all those caveats, I think the top 25 is what was called for in the statute. Obviously, these numbers, it's not like they're cutting off at 25, they just keep going down. Whether it was top 25 or top 50, I don't think there's like a natural break to cut these off at, but top 25 is often what's used in insurance reporting to look at your big ticket items. But we don't have in here what percentage of the total this is, which might be something useful, to add on. I just thought of that, Mary. It was like, because we could give the total units or the total prescriptions and total dollars, and that way we could sort of see. So how much of the total did that drug actually represent? So the first page that Nancy has up is the count of services. And so those are the prescription fills. Is that correct? Yeah, thank you, Mary. So these would be actual, so whether it's a 90-day or 30-day, we're not adjusting for that, or 7-day or something. So it's just a volume based on essentially a claim count or a prescription count. And you can see we've got Medicaid on the left column, Medicare Part D, that's represented in our all-payer data in the middle, and then commercial on the right. So just the basic service count. And I'm not going to go into individual drugs. Some of these I recognize, some of these you'll recognize, some of these we take, some of them you won't recognize, but these are names that are easy to look up and get an appreciation for what it's treating.
Yep.
Yep.
I've heard of some of these.
Yeah.
So looking at atorvastatin, does that capture both generic and brand?
Yes. Yeah. Yeah.
Okay.
So it's sort of rolled together, and statin something that has a myriad of doses too.
Right,
There's
so
tiny-
this is
yeah,
like
it's all
the
of them
10
put-
up or whatever it is.
Yeah, put all together.
Okay,
Yeah, so and so the same, I think the thyroid one next, that same kind of thing where it's multiple different doses. So these are like very common looking drugs when you look at volume, and I mean, I can find ones that I take or my wife takes or what have you. So these are common things, and by and large, obviously also low cost drugs. Low cost, yeah.
Okay.
I mean, but a lot of them are generic and have been around for a long time.
uh-huh.
What interesting we do see a sort of strange thing on some of these. We see on the right, the COVID vaccine, which is kind of interesting that shows up there. So that would be something that's obviously novel for this year's data. But I look at this and I'm like, oh, this is kind of data that's understandable. And then if you go to the next page, where it's this is the total allowed amount, which is a synthetic thing. It's what I said earlier, it's what the pharmacy was paid by the PBM plus what the patient was expected to pay. And so these are things that I'm, for most of these, I would have to look them up to know what they are. So these are much higher cost drugs that are not, you may find some things in here that were on the first list, but it's by and large, a very different list.
Can I ask another question? Is this like the final cost after all rebate?
No, No, unfortunately.
Okay,
So that is an area that we don't have a way of even adjusting, trying to adjust for. So this is, yeah, so that's a very important point, is that this is the essentially the cash that changes hands, and even that maybe not the case. In the case of what the patient actually paid, we don't necessarily have that, but
so
that's,
if they used a coupon, it
yeah, it
wouldn't
wouldn't be in
captured.
there. You know, certainly the transaction with between the PPM and the pharmacy is that it is the transaction, it's the actual paid amount, but then we don't know anything about what happened months down the road with rebates and other strange arrangements. Yeah,
So in saying that, it sounds like we don't have a benchmark of what's actually, what manufacturer ultimately collected.
right.
So if we're looking at what's paid at the pharmacy, which is one price point, but we are blinded to, if you will, back to thinking about the rebates and so forth, is what the net was back to the manufacturers. Therefore, that spread, if you will, that delta, which is going to somewhere in this pharmacy supply chain, is kind of lost to us, right?
With this,
But we do eventually get the Medicaid rebate.
yes, so Medicaid is an area where we could, you know,
And what
adjust
about
for
like
it.
this, you know, the employees and retirees? Because
Yes.
isn't this statute all focused on
Yeah,
the public payers?
That's what I was gonna say.
Yeah, so in a sense, it kind of doesn't matter what happens in the commercial world. But Medicaid, we do know what the rebates are eventually. And the self-funded employee and retiree, we would know also.
Right, so presumably, it's a good point, presumably you could adjust for those and, you know, at least get them a more
And
cleaner.
wouldn't
idea.
we want to?
I'm just wondering, you know, we're not so much worried about how much the manufacturer gets.
Right,
We care, I think we care about two price points, which is one, how much the person is actually paying out of pocket, which you said this does reflect,
sort of.
sort of. But two is what is the cost to whoever is carrying the policy, which would be in the state. I mean, yeah, these are state.
Right, so it'd be Medicaid and the
And the
retirees
retirees
and
and
employees.
employees,
So
exactly.
those two pools are,
So what is the cost? But to us, it really matters. What's the cost that we're putting out?
right. But, and we could get that rebate information at the end, right?
I know it's available for Medicaid, I don't know with the agreements with, say, administrative services for the state employees, it could be that that's available, could be that it's not.
I
We
could
should
think of it.
find that out.
Yeah. So if we take the drug class, do we know and have visibility into Medicaid and what the rebates are? That's coming back to the state, so therefore we have visibility into it. Could we then look at the net price that the state's paying, is the amount that's paid out, but then
The rebate.
once rebates come back, what the net is to the state? Could we then somehow benchmark that against the state employees and recover it?
If they're actually equivalent.
Yeah.
I mean, it may be a completely different.
Well, what's the state paying to Medicaid and what's it paying to the state employee
It's
program?
probably gonna be completely different
Yeah, I would think so.
Yeah,
for a few
I don't know.
But that's to be,
different
But
populations.
that's important.
and
Right.
Different,
yeah, I mean,
I mean, the state plan is smaller than Medicaid.
so that would be a good thing to talk with Pick Clifford about, and whoever administrative services is running the state employee. You know, I know that there's some contracts where it becomes kind of confidential. You know, we may not know at a drug class level, or we may know at a drug class level for any particular, you know, contract with your PBM. Or maybe, you know, maybe you thought about that, maybe you did, maybe you care about it, maybe you don't. You know, the Medicaid has the additional thing of the federal rebate program. So that sort of makes it, I think, quite different than commercial plans.
Can I ask a question? And this is reflecting ignorance, which I hate to do, but it is the case. So aren't the state employees and retirees really one big pool? So we don't, it's unlike commercial, we don't have multiple different carriers. And
I think
unlike
they're
Medicaid,
different
we don't have
carriers.
multiple MPOs.
Because there's the current employees, there's the non-Medicare eligible retirees. And then there's the Medicare eligible retirees who have a Medicare Advantage plan. And I think they're different carriers.
So it's
So I
not
think
a
Aetna has
simple-
part of it and Anthem. has part of it. But we could get, I think it's Cassie Keen still to come and
Talk to us.
talk to us. But the other thing that we pay as a state is the clawback on Medicare Part D. And that may be just something that is too abstruse to even think about right now. And it changes so much.
I think that's just set by the federal government.
It is,
Um,
but we can't influence
No.
anything, so I guess we should forget it.
Can I ask, I'm sorry, I have to step out for just a second. So I have, I think 4 questions, which you may have covered. So if you did, don't repeat yourself. But have you gone through these?
Just started.
Oh, okay, then I'll wait.
Let's go to the next page. So the other interesting part was to look at increased costs. And so that's what this does, this compares fiscal year 21 to 20. So it's saying what is the dollar change from one year to the next. So that would be, partly driven by the drug becoming more expensive, but more likely new drugs coming on. It might be interesting to do this just with the service counts too, to see how that's changing. That might be another advantage.
Is there a way to go back and take the increase, like the first one at 3.7 million?
What are these drugs?
What's
This is Remicade, first one.
the-
So these are biologics.
so therefore, what percentage is the increase from last time?
Yep.
As a percentage in here.
That would be a good thing to do. So it's interesting on the Medicaid. Medicaid, I'm much more familiar with, and tap buprenorphine as the third biggest increase. That's interesting and it's expected
What else?
from the increase in use of medication-assisted treatment in the state.
Oh, the buprenorphine.
Yeah,
Buprenorphine.
buprenorphine.
Uh-huh.
So this number, though, the increase is dependent on utilization. as well as
Utilization
price.
and price, right?
Uh-huh.
Right, so again, you could think about taking different slices of this, and we're totally happy to do it, with the data that we already have and look at percentages, look at rates and things like that, average cost kind of information. We just started these basics since that was what was in the statute.
So if we go back to look at that, is there a way to identify, it's back to the same thing, the claims, so therefore the count of services, which is count of claims.
Yes, we could divide one by the other and.
That was one of my questions.
Yeah, I think that's a fair idea. So it still wouldn't necessarily account for increased units or something like that. So if something shifted from 30-day to 90-day, you may not pick that up, but we could go at that level too. We do have the number of pills, we do have the milligrams, but the more you do with that, it lots of effect.
I would say this is definitely, thank you for doing this. But doing that is that we could then identify maybe 5 or 6 that we want to drill down in, not the whole 25, but maybe 5 or 6 drugs that we want to take a deep dive into it. And that gets back in the same thing and saying, what's driving it?
Well, the only caveat that put into that is that it's important to know, for example, adalimumab, that actually just went generic a few years ago. And so it's surprising to me that the increase in paid amount would go up unless it's a utilization factor. So
Which drug are you talking about?
the first one,
At a,
yeah. If the reason it went up is because of increased utilization, that's less worrisome benefits the per unit price going up. Because.
But doesn't it mean people are getting more of whatever illness?
Not necessarily. It just means utilization went up.
Oh.
And so there's an increase, a broader use of this.
To treat whatever. it is.
Rheumatoid arthritis, psoriasis,
Different
all sort of
indications.
colitis, Crohn's, any of the.
And one drug treats all those things?
Yeah, Sean Broccoli put a very important comment into the chat. He said adalimumab is a freeze on generic availability into sometime in the future. And that could be the issue in that it's not available generically, so it's all brand name.
Right, so that might be the jump, as Bill just said. So, but what I'm getting at is that before we pick a drug to look at, we probably should look at the per unit or whatever we're calling this on page 1, the membership cost of count of services. So per count would give us a much more accurate look at what's happening with the specific drug. So if we could break it down into per count and utilization, that would be, I think you could do that based on this data, right?
Yes, yeah. Yeah, I mean, I think each drug is a story, that to dig into. So you could go to every one of these drugs and have like pages of information. And but so I think focusing on some key ones maybe would give a feel for what the different patterns are, but yeah, definitely.
Yeah, just going back to Letterman, maybe the top 10.
Or anything over 1 million.
It is
But
also,
That first page didn't make a distinction between 30-day fills and 90-day fills.
Right.
So the count of services isn't really going to be quite enough
it's the interesting
information.
because we don't have the number of dosing units in the count. So, which is back to trying to get to Senator as well, is that, was it for 30 tablets and 90 tablets? We know we have a prescription, but we don't have the volume on that prescription.
Oh, we can't. No, we do. We do have the unit, the
So you
quantity.
could get
Oh,
that.
So we could do it that way instead.
You include units in there as well.
Yeah.
So the count of services, the count of prescriptions or claims, but we can get the number of units.
Right. And not just, a drug that's a common drug that's more likely to be prescribed 90 days, which is soon to the top, right, of that list. So it's sort of not as good a way to represent what drugs are being used by people the most, but it does then better adjust for cost to do that. It may or may not make much of a difference, but it's definitely worth looking at for these common drugs, since we have the kind of data all rolled up already. We can do that.
Yeah, so just to underscore my point, if you look on this page that we're looking at, the top 25 increases at a limit,
Adalimumab,
that's why I always call it Remicade, is number 1, but it's not even on the list
Right.
of count of services, whereas buprenorphine is number 1 on the list of count of services, and it's number 3 here. So
That's
per-
shocking to me that that's the most filled.
but it's Medicaid. And so I think
Still,
we know that Medicaid is like our foundation for substance use disorder treatment.
yeah, but
But it is shocking.
it's shocking when you think about who's on Medicaid.
right.
It shows you the magnitude of the drug abuse problem.
Yeah, it does,
Yeah.
because take out all the people in nursing homes and all the people with developmental disabilities and all the
Right.
kids.
It also
And you're
shows
left
you,
with a lot of substance abuse disorder
right.
patients.
And since we're going down that little rabbit hole, that it also shows you why it's so critical to keep Medicaid expansion intact.
Right,
Because otherwise.
which we have to do next year.
Right, next year. So my point, though, was buprenorphine is probably per unit nowhere near as expensive as some of these others, like Remicade. So it would be, I think that's why it'd be so much more useful to have per unit cost increase.
Uh,
And then we could look at, pick the top 5 or top 10 and do a deeper dive. The
I
other,
asked they can try to make the font a little bigger.
well, they were putting it on the page.
I know.
In landscape view. That's why I'm wearing my glasses.
And my glasses are not even helping.
So I just want to zip through the last couple
Yeah.
pages so that the page, the second to last page is what the patient paid. Medicaid is very small numbers because Medicaid is like a $1, $2 copay. So if you go more to the right now, there you go. So this would be what the patient's
okay.
expected to pay and, you know, again, there are things that were common to the prior list, but also you know, the patient paid obviously is influenced by volume quite a bit. So some of the things, you know, this is much more common with the service page than that total cost page. So anyways, and again, this is,
The Medicaid one.
It's over on the left.
Yes,
There you go.
so the Medicaid amounts are very, very small, which is what we
So
expect.
could we possibly make two columns where it says the total paid and the patient paid? Instead of having two separate,
But they're different. So they're a different set of 25.
okay,
So the drugs that have a high patient paid amount aren't going to be necessarily the same drugs that have the total paid amount.
so if we do that there.
We could do it. We could,
Right.
yeah.
But you have to have two different ones going to be sorted by the amount total paid versus the amount patient paid, but you have both of them side by side. What I'm trying to get to is what percentage of the total is being paid by the patient.
Right. Well, we should, yeah, maybe do a separate table
Yeah.
for that.
Okay.
Yeah. That's a good addition.
This is omeprazole over the counter.
But it's still prescribed.
Oh, it is.
It's like Motrin, so prescribed,
Oh,
ibuprofen.
Yeah, you can, you can't, I mean, you can prescribe 40 milligrams of omeprazole.
oh, okay.
You can also prescribe a 20 milligram, but it's usually in the commercial world, it's usually rejected.
Uh-huh.
But that'd be helpful, I think, just looking at what the impact is to the patient versus how much the total paid is. And again, the other thing, not to make it more difficult, is if we identify, say, 10 drugs we want to look at, can we look at that over longitudinally over time?
Yes. Yes.
Because it could kind of get a multi-year. So not looking at just a snapshot, but trying to get a trend.
Right. And I mean, I think there are going to be some, they're always going to be there. And then there are these new ones that come in and yeah, it's certainly true that there are drugs on the total cost list that are, you know, obviously, if we look back in time, wouldn't have been there. And so newer things and a lot of the drugs from a volume perspective, obviously, like statins have been around for a long time. But it's really the cost for new things that are coming to play for a lot of these. So the last page is the drugs that have had the most increase in patient paid. So these are taking the fiscal year 21 patient paid amount versus fiscal year 20. So these would be the places where, by and large, patients are paying out more for in 2021 than they did in 2020. Again, it's the total amount not adjusted for the volume.
It goes back to this, you know, what's interesting, this, besides the cost factor, I think Senator Roosevelt also touched upon it. You look at Medicaid, the top one, I believe, is Adderall.
Mhm.
Oh,
Is-
is that what that is?
Yeah, so therefore, when you start looking at it over time, it's back in the population saying, what drugs are being utilized?
Well, you always read that New Hampshire kids
Correct, so
have high numbers of psychotropic drugs prescribed for them.
Correct.
And
it
sort of
just validates a lot
suggests-
of what's there. So it's not just a cost factor when you start looking at the drug utilization, start looking at patient population, which drugs are being utilized by the patient population.
Wow.
I just,
Part of it.
I just put back in the caveat that this would be much, this is great. It would be much more valuable and compare it if you had the per unit.
Per unit cost.
Uh-huh.
Okay.
Can you go back to the Medicaid list for a second? Stupid question. What is simple syrup doing there?
Well, this is the maple syrup state.
Well, no, but seriously.
Do you remember, Mayor?
It's cough syrup. People use it.
It is. And they
Yep.
don't make it on their stove at home like we do.
And Sean Buckley says it's also used for compounding medications, which
Yeah.
is true.
And the
Yeah.
Medicaid data here is sort of a little deceptive because you have to be above a certain income. You have to be an adult, you can't be pregnant, there's only a certain box of people actually paying a copay. So it's sort of a weird set
Well,
of data.
you're not required to pay it even if
Yeah, if you
you're
can't
asked
pay,
for it.
right. So it's sort of not, we put it there for completeness sake,
Uh-huh.
but I wouldn't.
Somebody had
just-
a hand up. Not Lise Fernand from New Hampshire Medicaid.
Let's look at participants. That'll tell us it.
Okay,
It's the,
at least
Lise.
maybe wants to tell us what's
Lise,
going on
yeah.
with simple syrup.
So let's do an allowed to talk for release.
The next
Release.
one.
Moran,
Down one more,
right there.
jumpy. She's up mid.
Just type into the top and search. See what's on the top. There she is.
She's unmuted.
Lise, you want to make a comment?
What does more do? Does it give us?
Sorry, I trying to find the unmute. Sean did explain it well. It's used for compounding in our Medicaid population.
Okay. So simple syrup is different than maple syrup. Okay.
No less therapy.
No, that's there.
So Mary and I can certainly put together those more kind of rate changes and rates or average costs and that kind of thing, and send those along. And, I think I like the idea of picking, 10 drugs or something and getting more detail on that, trends and things like that, after we do that piece of work, I don't think it'll be that much work, but, whether it's, you need us to come back or not, that's fine.
If it's okay with you, I'd be more than glad to work with yourselves.
Yeah.
And talk about some of the ways to present the data. If it's okay with the board, it's back in July, we can look at some revised numbers.
I think that'd be great. I mean, that really would capture my questions, which are really looking at, I think the data will be more valuable if we break it down by per count, maybe by per patient or however it makes sense. And then once we have that, then we can pick the top whatever number we choose.
Oh, absolutely. And I would have suggested that at the start anyways, but
But
we
this is
partly had to
great.
do this, I think, because the statute literally calls for this particular view. So, but, to analyze it, you obviously do need that per unit, per claim view of things.
Right. So this is awesome.
Can we see what we can get from the employees and retiree plans? Whether they can break it down the way Andrew has, if it's not really correct in the database.
Can we break out the state employees, the commercials?
We have the group plan ID,
Yes, we can.
so we should be able to figure that piece out.
Yeah, I
I'm
mean,
not certain we're gonna know if there's a Medicare for D, I don't know what that equates for the retirees. They can have something on that.
Okay,
The reason I ask for that is the focus really here is on what we're paying as a state.
Right.
Medicaid.
and we're paying that,
We're paying that.
So
part of it.
and I think if you could find out what the state administrative services has in terms of the rebate, what they may get it like the therapeutic class level, sort of broader groups, and then we could try and match those groups, with whatever they have on the rebate side. I think, because that could really change the view of what you consider the most expensive drugs. Probably not going to affect what the patient's paying is what the data we have is probably good for that, but.
Well, if I could just add, while it's most important to us what the state is paying, I think it's almost equally important what the patient is paying, because we could pay zero, they could pay the whole thing, and the state looks great. Except it doesn't feel so good on your wallet. So I think those are the two balances. But one of the concerns that a lot of our critics had was we don't want to be going down trying to provide necessarily price controls and those kind of things for manufacturers. We're looking at what's the impact on the state and on our employees of the cost. I think keeping that clear. This is really great stuff. Thank you so much for doing this.
Absolutely. No, it's a great use of the
We've
data
led the
set.
way on this database.
That's right. And I think it's an underutilized part of the data, so it is really good to see it being used more in depth for something like this.
Thank you for pulling it together.
Absolutely.
And step up and leave us out of the studio.
When I slide up, I'm gonna dial back.
So good morning, Mr. Chairman and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan and Gartrell, and I represent AHIP, which is America's Health Insurance Plans. I really appreciate the opportunity to present to you this morning, and also for allowing Sergio to participate remotely. That we really appreciate that accommodation and flexibility. So today we have the presenter from AHIP will be Sergio Santiago, who is the Vice President of Drug Policy for AHIP. He has a law degree from the DePaul University College of Law in Chicago and has worked in government affairs for over 20 years, representing not only insurers, but providers, pharmaceutical manufacturers, wholesale drug distributors, and PBM. So he's very familiar with many perspectives on the prescription drug issues. And so with that, I'll turn it over to Sergio, and I think we'd be happy to take questions, as the presentation unfolds. So, and I know he has slides as well. So.
Does he have?
Yes, I'm sorry, go ahead.
I was just going to make sure you can share his slides.
Yes, I will. Thank you very much. And Mr. Chair and members, I'm going to be sharing my screen right now. If you'll indulge me for a moment. I'll make it nice and big so we can all see, especially for my benefit, since my eyesight isn't always the greatest. Well, as Heidi said, my name is Sergio Santiago, and I thank you for giving us this opportunity to present to you today. I am Vice President of Drug Policy at AHIP, and as you mentioned, I got some background out here, having worked on this for some time. So I can hopefully help you all see a lot of things from our perspective, and certainly try to do that in less than 30 minutes. And give you all as much time for questions as you'd like. And to that end, please feel free to interrupt me if you have questions on any of the slides. I'm happy to address questions as I go along, however you all prefer. I'm perfectly comfortable however you want to do this. So with that, thank you again for this opportunity to speak about high-price drugs and the payer's perspective. Briefly, AHIP is a national association. We provide health insurance for hundreds of millions of Americans. We represent all of those health insurance providers, or most of them at any rate. And our goal is to use market-based solutions and public-private partnerships to make healthcare better and more affordable for everyone. Our first slide is our perspective on, where does your healthcare dollar go? And this has to do with your premium dollar. In terms of every dollar that we spend, that we collect from you, 21.5% or 21.5 cents goes towards prescription drugs. 19 cents of that dollar will go to inpatient hospital costs. 19.8 cents will go towards outpatient hospital costs. 3.2% will go towards emergency room costs. 12 cents will go to doctor visits. 6% goes to other outpatient care, just random clinic type stuff like pop-in clinics, that kind of thing. And then the
Sergio,
remaining, yes.
Question, when you talk about prescription drugs, are we breaking out prescription drugs used while patients in the hospital or also in the outpatient basis, or is the outpatient and inpatient cost prescription drugs in those two columns?
I think we're focused here on the total spend. Some of it can be broken out because some physician administered drugs are provided in the outpatient setting, but we try to coordinate or compile as much of the prescription drugs in its own category so that it can be shown exactly how much of that is actually spent on drugs. There's certain things, of course, like inpatient services, like if you're in for surgery and you get aspirin or Tylenol 4 or something else along those natures, those are part of diagnostic related groups and inpatient patient payments that we're not necessarily going to have that kind of breakdown for. So for sake of simplicity, we tried to pull out everything that was readily determinable towards prescription drugs.
So if I can reframe it, so basically whenever the drug is billed as a separate component, we're able to pull it out.
Yes. And in some cases, we may be able to, some of the PBMs may be able to, if they are integrated vertically with the health insurance plan or they have certain agreements, but generally speaking, it's very hard to pull that information. It's not impossible, it can be done, but part of it also is there's a lot of access issues in terms of, PBMs having access to every medical claim or every kind of detail. So I think, it's fair to say that this is a pretty accurate picture. It's not entirely down to the exact tenth of a penny, but certainly it gives you a broad picture that, if there is a slight adjustment here, it's not substantial, depending on how you want to define it. Mm-hmm. And then just to move things along, we have the other 4.6 cents is broken down onto other fees, business expenses, cost containment, taxes and fees, quality improvement, other administrative offenses, and 3 cents out of that dollar goes towards our profit. So we have a small margin. As you are probably aware, we have requirements under federal and state law to impose to operate under what's called a medical loss ratio, or MLR. We are basically, in most cases, required to spend 85% or 85 cents of every medical dollar that we receive from patients on medical care. And that 15% is generally left over for administrative costs, for the actual operation and administration of the benefit for patients. These numbers are slightly adjusted in the small group and individual markets, but again, it's 80-20 versus 85-15. And the rules are very specific. The administrative costs includes things like customer service lines, provider engagement, PBM services, fraud and abuse prevention, accreditation costs, marketing, operating costs, claims administration, the actual process of administering claims. All of that falls within that 15%. That if we exceed that 15% on administrative costs, we must rebate the difference to patients directly, our customers directly. The medical costs are very broad, but they include doctor visits, healthcare provider visits like physical therapy, hospital stays, prescription drug costs. And I wanted to highlight that is net of rebates. So if we are able to get a drug and a rebate of say 15% on a drug, we don't count the lower cost of the drug towards MLR. We count the full cost, the list price of the drug towards those administrative costs. So we don't get to play around with those margins in terms of saying, oh, well, we save 15% on this particular drug, Therefore, we have more to spend on administrative costs. That is under the law and under the rules, we cannot do that. It is the actual cost of the drug, not the negotiated rate. And then
Here we
lastly,
have
sure, go ahead.
Jennifer Roosevelt.
Thank you. Where does profit also get put into administrative?
Administrative costs, yes. That is correct, ma'am.
Heard of one question also, talking about prescription drug costs.
Mhm.
Are those again drugs that are what I call Plan Part B, which is the medical side of the equation? We're not dealing with the pharmacy benefit plans.
Yes,
So we
that
talk-
includes outpatient physician administered drugs. So if you're going to a physician, whether it's a clinic or it's a hospital, outpatient clinic, if you're going to get an injectable drug or an infusion, those drugs are included. This
Thank
is
you.
not the, as you said, this is not the inpatient when you're admitted as part of a medical procedure. These are strictly physician administered drugs and retail drugs that you go to the retail pharmacy or mail order pharmacy, et cetera. I also want to add that quality improvement areas activities are included under medical costs, and this includes things like value-based designs and outcome-based designs, things that are designed to improve care. Again, all of this is reported in great detail to health insurance commissioners and to the federal government, depending on the type of plan we're talking about, but all of them are subject to MLR requirements.
So the drugs filled at a pharmacy are included here as well.
That is correct. All part of the medical costs. Now, the actual administration of the claim is an administrative cost. So the cost of the drug is part of the medical costs, but the cost that we have to incur to process the claim is part of our administrative costs.
Thank you.
Mhm. So broadly speaking, what drives high drug prices? We view 4 themes and they all revolve around pharma. You can start with pharma. You can then proceed with high launch prices. We have a broken market. We have unsustainable spending, and then we have excessive price increases. All of this is largely controlled by the manufacturers. So when I refer to pharma, I mean all the drug manufacturers and primarily the brand drug manufacturers. There is some issues from time to time with generic drugs, but by and large, we view generics and generic competition as essential to keeping drug prices from going even higher, frankly. So we work with the generics manufacturers, and we prefer their products whenever they are available. They're not always available, of course, but our generic effective rate or fill rate, generally speaking, is roughly 85% or higher, depending on the type of plan that we're discussing. But it has been a priority for insurers and PBMs to utilize generics as much as possible to help mitigate those costs. As you can see from the slide, we wanted to talk about a little bit about rebates, and of course, I'm happy to answer questions on this. But one of the common refrains we have from our critics, and particularly from the drug manufacturers, is that our ability to negotiate rebates is somehow driving up higher costs. Frankly, this is a complete, self-serving statement, and it's not particularly logical, I would say. Because we're able to negotiate a discount, they have to raise their prices. I don't know that that's necessarily how things work, but that's not been my experience in 20 plus years in this type of industry. But for what it's worth, I wanted to emphasize that health insurance providers are America's bargaining power. We're the only ones in the drug supply chain that are working to negotiate lower costs for everyone. Insurers will pass on those savings to consumers either through lower out-of-pocket costs and or premiums. Again, through MLR, and also through Medicare and Medicaid rules, we have certain, and depending on the clients, if we're talking about private insurance, we are bound by competitive forces, and we're also bound by laws and regulations that require us to treat rebates in different ways depending on the type of plan that we're talking about. I can go into that in greater detail, of course, but most rebates are passed on to the client from the PBM directly. That's called pass-through. Other times there is, not as frequently, but there are other options where A PBM may offer a lower price than the pass-through price, but they keep a small portion of that rebate as a sort of compensation on top of the administration costs. But again, most plans also have to divulge how they are using those rebate dollars. And depending on the law or the type of plan, in Medicare, for example, they must apply that to premiums or other reduction of out-of-pocket costs. Most plans do the same thing because it's a way to help mitigate the high costs of prescription drugs and other services, depending on their risk pool that they're working with. So the idea that our ability to negotiate discounts is the only check on the ability of pharma manufacturers, particularly the brand manufacturers, from raising costs further.
I have a question on this.
Sure.
Real quickly. We've had, I think it was 2 years ago, the last biennium, we had some state level initiatives through legislation to decrease, I think it was rebates. And the concern that was coming up was that PBMs are capturing the fiscal benefit of the rebates and not passing it along to the consumer. So they're increasing their profit while not doing exactly what you said, which was decreasing, allowing this to decrease premiums or decrease out-of-pocket expense to the consumer. Are you saying that there's federal protection now against those practices by PBMs?
Well, first of all, I would disagree with the characterization that they are capturing profits in ways that are somehow against the law or somehow, improper.
But no, improper is the right word. I'm not accusing anyone.
No, of course not. And believe me, I didn't take it that way. I apologize. I'm trying to find a way to describe it. But obviously this is a very complex issue, and it's very easy to say that, PBMs are just middlemen and they're taking a bit off the top. But the data shows, and I was going to say, if you look at the rest of this slide, for example, there are multiple analyses, but I highlighted 2 of them here. One by, and forgive me, I'm going to have to look at it because I forget the exact name of this group. It's the Affordable Prescription Drugs organization. I believe it's an advocacy group that pushes for lower prices on prescription drugs. Did an analysis that showed that compared the increases for rebated and non-rebated drugs, showing that rebates don't drive higher price increases. And the U.S. House Oversight Committee undertook a multi-year investigation into drug pricing, and they found, again, through these 2 data points, for example, and the links are included in my presentation that were submitted, but the data, which has never been shared with the public, they collected a lot of actual, transaction data from the manufacturers and the PBMs themselves. And they concluded that it undermined industry claims that price increases are primarily due to increasing rebates and discounts paid to PBMs. In addition, PBMs secure contractual provisions that disincentivize drug companies from raising list prices. Without those provisions secured by PBMs, drug companies likely would have raised list prices more. And then one last point before I address more of your question. I also wanted to highlight that not all drugs have rebates. It is a common tactic for our friends in the manufacturing industry to say that, they're keeping all the rebates, but most of these drugs, especially the key factor here is whether or not a particular drug has competition in its therapeutic class. And if there's a drug, like many biologics for now at this point do not have competition, that is the key lever by which PBMs are able to lower prices or secure discounts and rebates. So if a drug is exclusive and there's really no competition for it, there's no incentive for a manufacturer to offer a lower price. And that's why, frankly, because these are really expensive drugs, these specialty drugs and biologics, and I'll go into that in a little bit more detail later, a lot of research is moving in that direction. Their research pipelines are focused on specialty drugs because it is much harder for competitors, especially generics, whether it's through biosimilars or interchangeable biosimilars, which again, I'm happy to go into in greater detail. It is much harder for competitors to emerge in those particular specialized areas. So again, as far as are there other protections in place, there are certainly new requirements that Congress has imposed in the last couple of years on employer-sponsored plans and individual plans that require, sort of an aggregated reporting by PBMs of their rebates. It's not broken down drug by drug, PBM by PBM, because that's competitively sensitive information. But it does provide some more public disclosure into those pricing practices. And I believe those will be available in publicly searchable databases for research. But I don't know, honestly, if those have been stood up yet. But there have been a number of steps over the last few years to try and introduce more transparency into some of those practices. And, frankly, I would say that some of them are anti-competitive because it will allow pharmaceutical manufacturers to engage in more shadow pricing or practices that will allow them to see what their competitors are getting and or what PBMs are negotiating what. They will be able to gain some insight into that, so that'll allow them to play games with the pricing. So I think those are some of the main points that I think get to your question, sir.
Okay. Thank you.
You're welcome, sir. Let's go to the next one. Other factors that are driving high costs for patients. There are government granted monopolies. This is, of course, the patent for the drug, which is, again, I would highlight that we are not opposed to pharmaceutical manufacturers making a profit. We understand the role that plays in driving their research and funding their research. I would say that they exaggerate a little bit how much that contributes to their research pipeline down the road. But that's another discussion for another time. But we do agree that they deserve to deserve the fruits of their research. But we would also say that some of those monopolies are a little bit too long, and more importantly, there are ways that they have manipulated the patent system, whether it's tweaking a product by a molecule and then applying for a new extended patent. It's called evergreening, or other similar sort of patent approaches like thickets, like putting a bunch of different patents around different aspects of the drugs or other potential uses of the drug that limit competition. So again, that contributes to this market dysfunction, and that it hampers competition, which is what we're after the most. If we can have multiple drugs competing each other in a therapeutic class, and even better, if we can have generic drugs competing as well, then we can really save patients and plan sponsors a lot of money. And that includes governments, whether it's the state or federal government. Ultimately, there are also challenges on our ability to implement certain cost-saving measures. This includes things like utilization management, where we will require for certain drugs step therapy or prior authorization. It's understandable that everyone wants to get the drug that their doctor prescribes, but the reality is there are times where the doctor isn't necessarily aware that there may be other competing treatments under the conditions that he prescribed the particular drug that merit trying out another one first that is less expensive but is equally successful or has a similar profile for success. These are important ways for us to contain costs. And again, we provide exceptions. We provide opportunities to appeal any kind of decisions, and those decisions do get overturned. But these ultimately limitations on our ability to impose some of these cost-saving measures. And again, most of these are determined by our clients, whether it's governments, whether it's unions, whether it's private employers. Usually they are the ones who tell us exactly what they want. And I would point out that many of the insurance manufacturers employ us to manage their prescription drug benefits along with their medical benefits, and they ask for these same tools themselves. So all of these limitations, along with the market dysfunction and government granted monopolies, will result in higher launch prices, large increases that happen multiple times a year above the rate of inflation, and unsustainable spending on prescription drugs. And again, these are all, and you can see from the graphic, some of the tools that we use and some of the methods or legislative initiatives that have impacted our ability to impose cost saving measures on spending for prescription drugs. These include things like, preventing us from limiting copay coupons, putting caps on our copays, For delay is a reference to prescription drug manufacturers paying a generic competitor to stay off the market, even though they have first to file rights to enter into generic market, their product to compete against them. Certainly, frozen formularies where we're not allowed to make formulary changes, regardless of whether a generic enters or not. Coverage mandates, coverage parity, things of those nature all add cost on patients. I'll just mention briefly, again, happy to answer questions on this, but one of the areas that we found the manufacturers have really pushed in the States in particular is the idea that we are somehow denying people access to drugs by limiting the ability of our enrollees to use copay coupons. Copay coupons are a marketing tool designed by the manufacturers to get patients past their deductibles so that the insurance sponsor will pay the balance of their drug for the rest of the plan year. And that adds significant costs to prescription drugs, particularly when there are generics available or other competitive products that are available. So there's a host of studies that demonstrate this. And for what it's worth, I would add also that Medicare and Medicaid do not allow coupons, as they view that as a violation of the anti-kickback statute, because it's incentivizing the use of product in exchange for a reward. So Medicare and Medicaid have repeatedly rejected any appeal to lift the restrictions on copays. So again, happy to discuss those in greater detail, but I just wanted to bring that to your attention. Other proposals that perpetuate a broken market, and I'll go into these in a little bit more detail, but copay caps, of course, sets a maximum or fixed amount for a patient's cost sharing for a drug. This creates what's called a balloon effect, where it may bring relief to some patients on some drugs, but other consumers are going to have to pay more to offset. It's a cost shift, is basically this balloon effect is a fancy way of describing a cost shift. So everyone will pay higher premiums so that some can get an additional discount. And this does nothing, copay caps do nothing to address the underlying cost of the drug itself. It only focuses on what we are trying to do as an industry to help people afford these drugs. Frozen formularies, again, as you're aware, we have our plans implement formularies. We work with PBMs sometimes to do that. And it basically inhibits our ability to replace drugs with new clinically appropriate and less expensive alternatives. We are committed to providing those alternatives. And, whenever there's a change in formulary, for example, if a brand drug, there's a generic entrant and we can change our formulary to prefer the generic over the brand. The idea is a frozen formulary law would prevent us from doing that. So, or the entry of a new drug in a new therapeutic class that treats another drug, another brand that treats the same condition as another brand drug, but is actually cheaper. We can't prefer the lower cost new brand drug over the existing brand drug because of a frozen formulary restriction. And then another topic that you hear a lot about, certainly in the last couple of years, is the idea, and this has been one that's been pushed primarily by the manufacturers, is the idea of having point of sale rebates, whereby any negotiated rebates between the plan and PBM and manufacturer are passed directly to the patient at the pharmacy counter. Again, this gets to what I was saying about the balloon effect and cost shifting. And if you recall back a couple of slides, I mentioned that not all drugs are rebated. So a portion of drugs that are rebated are going to go to patients that use them, but everyone else is going to have to pay higher premiums because the plan can no longer use those rebate amounts to lower cost sharing or premiums for everyone. They are going to be forced to go directly to that patient, which is beneficial to the patient in that sense. But you could be looking at a situation where a patient who is receiving a rebate on a particular drug may be paying less for that drug, but they may be paying more overall for premiums that it may even offset the savings that they're getting from that point of sale rebate. So again, we understand the attraction of some of these approaches, but they run unfortunately into the economics of the market and the economics of how insurance and providing benefits works. And so, we urge strongly and push back as much as we can to explain, how these processes work, and demonstrate that these really are designed more than anything else to benefit manufacturers and give them either cover or leeway to continue raising their prices higher than they do already. Wanted to turn towards physician administered specialty drugs, and these are drugs that again are usually administered by a physician or by a medical technician, whether it's a PA or a nurse or at a hospital outpatient clinic. These are not drugs that you're normally going to be able to get from a retail pharmacy counter. So what are these drugs? Again, usually are not self-administered by the patient or the caregiver. They're either infused or injected in an office setting or infusion center or a hospital. They are usually very expensive, often biologic. They treat complex, chronic, and rare conditions, cancer, multiple sclerosis, rheumatoid arthritis, and so on and so forth. They also have, special handling and or administration requirements like ultra cold storage and ultra cold, maintaining a cold temperature for transit, maybe exposure to light, that kind of thing. But and more importantly, they are typically very effective drugs. These are I hesitate to use the word miraculous, but in many cases, they are really an amazing breakthrough in the treatment of a lot of these conditions. So we want people to have access to these products, especially when they're able to keep people from going to hospitals, going to emergency rooms, and having to avoid other more uncomfortable and painful and costly care that can be avoided potentially through these drugs. But unfortunately, these are very expensive drugs, and they inhibit our ability to really get the full value of the promise that those new treatments bring, because the cost makes it so much that it makes it very hard to pay for that and still provide low cost coverage for patients. I would point out that a number of specialty drugs, the number and price of specialty drugs have increased rapidly in recent years. Again, as I mentioned, it's a lot of work and a lot of money goes into developing these specialty drugs, especially if they're biologics. These are not easy drugs to develop and manufacture. However, there is room to question exactly the pricing strategies that the manufacturers have taken on some of these drugs. For example, I'll point out, we all remember the hepatitis drugs, Sovaldi, Harvoni, and so on and so forth. And, one of the manufacturer of that drug said at the time that the rationale for charging over $100,000 for the pill, and this was before they had competition, was that it was cheaper than getting a liver transplant. And so we would argue that that's not the correct metric. They took a percentage of the cost of a standard liver transplant and said that this was a worthy benchmark for us to set that price. I would note that within a year, other competitors for that same drug, for that treatment in that therapeutic class emerged, and those prices were halved and actually reduced at some points lower than what Europe pays for those drugs at the time. So, the notion that, these drugs I should say, some of the rationales under which the pricing of these drugs take place are very dubious. And, we need to have, again, in the case of the hepatitis drugs, our ability to negotiate competitors against each other was the key factor in our being able to lower that price significantly and increase access to those drugs for patients. Couple of studies there I've linked. One shows from AARP that specialty drugs were 13 times more expensive than brand prescription drugs, again, not generics. And that the Journal for the American Medical Association noted that specialty drugs are a leading contributor to drug spending growth. Traditionally, these drugs are provided by hospitals or physicians' offices. They usually purchase these drugs themselves directly from a wholesaler and then bill the health insurer for both the drug and the administration cost. It's called buy and bill. We have found that this is a wasteful and expensive, practice that really that really increases costs for everyone except for hospitals and doctors who are administering these drugs under their sites of care. And again, JAMA, the study that I cited here itself noted in an article that physicians and hospitals face limited incentives to mitigate the spending. And I'm happy to go into that in greater detail. AHIP has conducted its own research. In addition, we've cited some other studies here showing the similar trends, but we've analyzed the cost of 10 particular physician-administered drugs, and we found that on average, hospitals charge double for that prices on the same drugs than what we could acquire them for through a specialty pharmacy. Costs for single treatment of drugs administered in hospitals were on average $7,000 more than those purchased through specialty pharmacies. Physicians' offices weren't comparatively as high, but they were still $1,400 higher per dose on average than they would be if they were acquired from a specialty pharmacy. And these findings have been confirmed by similar studies in other publications like JAMA, Bernstein Group is a consulting group, and the Moran Company is another consulting group, found ranges anywhere from 169% to 344% markup of the Medicare payment limit on some of these drugs. Some 24 medicines on average by 250%, and so on and so forth. And I want to be mindful of your time, and I'm happy to answer these further questions, but you'll see in the inset here under the one pager that we have, all of those drugs that are listed there in the disparity between the prices charged at the hospital and physician setting. We provide more information in the appendix on those particular drugs, including the sourcing and how we got to those numbers. So happy to explain that a little bit further. Really briefly, I know that's out of the purview of this group, but I wanted to highlight that, to combat these growing prices and facility markups, we're employing specialty pharmacies, which are pharmacies that are dedicated specifically to handling these particular kinds of high cost, highly delicate drugs, to source these drugs and disrupt the buy and bill practice. The idea being that we focus on acquiring the drug from the specialty pharmacy and provide it to the provider, who then administers the drug in whichever setting is appropriate. The difference is now we are paying the pharmacy, we are paying the physician or the clinic or the hospital for their service in administering the drug, not the cost of the drug. We found that this has been pretty significant. A lot of clients have done this, whether it's public or private clients, and in different settings, it's been very, very successful. And again, this is just a little more detail about how it works and what our commitment is to, patient safety. Obviously, there are many safeguards built into this. There's coordination of care involved. And the idea is that this would be, as seamless as possible to the patient, because the primary arrangement is between the insurer having the specialty pharmacy send those drugs to the provider. So ideally, the patient will never even know where they got their drug, because normally they don't even care. They just want to make sure they get their drug when they go see their doctor. Specialty drugs, again, what are states doing to mitigate high specialty drug costs? We encourage the cost of specialty drugs be included in any consideration of drug price growth, whether it's through inflation indexes or consumer cost pricing indexes. There is a tendency for some to apply or just discount specialty drugs, since they are physician administered drugs and not retail pharmacy drugs, from these kinds of computations. And we think that's very important to include them, because they are driving the most increases in prescription drug spending. The brand drugs, the generic drugs, the traditional small molecule drugs that we refer to in those cases, the stuff that you normally get from over the counter, or at the counter, not over the counter, the rate of growth on spending has been relatively stable at or around the rate of inflation. And that's through the work of PBMs and plans to help keep those costs down. But unfortunately, the average increase in specialty drugs is year over year. So again, just highlighting some of the benefits of using specialty pharmacies in this way. You'll see that Purdue University and in a report from the Indiana Department of Health detailed a story of cost saving by the use of what is often called either alternative sourcing or white bagging using specialty pharmacies to disrupt the buy and bill practice. They're saving $179,000 over year on a single drug, and they're expanding that further. So again, I know I threw a lot of information at you, and I'm sure you have questions. So I'm happy to answer them, if you have them, and or follow up with you afterwards if you think of something later. But I'll stop sharing now and give you all control back to you.
Thank you for that presentation, Sergio. A couple of things on some of the studies that you referenced in these slides. Is there a link to the study?
Yes, they should be functional links to links to the studies in the document that we forwarded to you. If not, let me know. I'm happy to forward them to you as soon as possible.
And also in regards to specialty pharmacies, can you speak to the patient or the provider's office have any flexibility about which pharmacy they utilize?
So if I understood the question correctly, it's does the physician have a say in which pharmacy they use for acquiring their prescription drugs for dispensing?
Correct.
For specialty drugs under these arrangements, no. The physician, under the terms of our contract with them and as part of our insurance coverage with the patient, will either choose to accept the drug from the specialty pharmacy, or they will be considered out of network.
So the physician at this point in time is taken out of the equation as far as the acquisition of the drug.
Correct.
Okay, thank
Now
you.
they can choose, of course, whether or not to participate in that arrangement or not. And we certainly have flexibility. A lot of plans and PBMs are more than willing to say, if you're willing to match or come within a range of the acquisition cost that we would get through the specialty pharmacy, then we'd be happy to let you, acquire the product as well and pay you for the cost of the product. But part of the reason, and I'll give you a slight behind the scenes view of how that works. The reason why we have worked on trying to disrupt that buy and bill practice is that Medicare and Medicare Part B, the way they reimburse physicians for these drugs is they take a percentage of the cost of the drug, the average sales price of that drug that was acquired by the physician. So if it's a $1,000 drug, they will be paid 6% of that drug's cost for their administration services. So their payment is 106% of the price at which they bought the drug to administer the patient. Now, we're not saying that physicians are unscrupulous, but there's very little incentive to look for a lower cost source for a drug if you're getting paid based on the gross. So if I could get that drug for $800, I would get 6% of $800 instead of 6% of $100. And so why would I want to find the cheapest source for that drug if I'm going to get paid less for that drug? And I think that's the practice that we're trying to disrupt. And unfortunately, Medicare is the 800-pound gorilla in much of negotiated in setting the market in terms of what employers, for example, and private sponsors are going to get for a lot of these drugs, and for making these reimbursement arrangements and contracting with the physicians and the hospitals. So it's very hard for us to have leverage because we need to have the doctors, we need to have the hospitals in our networks for access requirements, not just in Medicare and Medicaid, but also in private plans as well. We have some leverage, but we don't have a ton of leverage. So to the extent that we can, we do try to, use our ability to say, hey, look, we can't keep paying for this arrangement. We've got to find another way to do it. So so that's just a little bit of background on some of the nuts and bolts of how those negotiations work and why specialty pharmacies and white bagging has really emerged as a counter to some of these traditional practices.
Thank you. And also, is the PBM world, if you will, part of the medical loss ratio?
It is part of the administrative cost. So anything that we pay the PBM to do whatever it does is reported, and it's also part of the administrative cost.
It doesn't go into the medical cost.
Does not go into the medical cost.
So therefore, if the pharmacy, specialty pharmacy is owned by the PBM, and the PBM is owned by an insurance
That's claim
company,
administration, and those claims are paid through the administrative side of the MLR.
but any profit that's made on the pharmaceutical in that channel does not get reported in the medical loss ratio.
So
if
we are only reporting what we've contracted with the pharmacy and what we've contracted with the PBM for those particular claims. We can't speak, we have no insight into what profit they are making, but they are also required to report, through the SEC and other financial filings, what their profits and losses are and what their margins are and things of that nature. So that's frankly outside the purview of MLR. But, obviously, like any business, they're in business to make money. But at the same time, we're paying them for the service. We're not paying them for their profit. We are not responsible for the profit margins, reporting the profit margins of every entity down the line. We are responsible for reporting what we are paying them to do and what is they're doing that is contributing to either the administrative cost or the medical side of the MLR. Does that make sense?
So I'm just to be clear, I think I said it correctly. So in other words, if the insurance company owns a PBM, anything that's going on in the PBM is outside of the medical loss ratio.
That's not correct, sir. The MLR, no, because even if it's part of an integrated entity, if it's a vertically integrated entity, they own the PBM and even a specialty pharmacy. Those
Right.
services have to be accounted for in the MLR. Just because they're vertically integrated doesn't mean that they are exempt from reporting what they paid or what is the cost of the services provided by the PBMs and how that is calculated as part of the MLR. Those aren't exempted from reporting. Now, their profit margin is not part of the MLR reporting. That is correct. But the services that they provide and the patients funds to pay for them are reported.
But their profit margin is not reported.
It is not part of the MLR.
Right, thank you. Thank you. Clarifies it for me.
Now, I would say though, however, that, depending on, we do have to report our profit margin. And so that may or may not include whatever portion of the PBM contributes to that, if it's an integrated entity or the specialty pharmacy, but
Right.
it has to be directly related to the provision of care.
Understood.
Okay.
Yeah, thank you, Mr. Chairman. I was just gonna call to the committee's attention that, I think you're probably aware of this, but the New Hampshire Insurance Department every year does a healthcare premium and claims
Right.
cost drivers. So, in that, I pulled the most recent one, but on pages 45 and 48 of that report, and it's not anything I handed out, but, it does talk about the, pharmacy costs under the medical benefit. And it also does indicate that specialty drugs have become the major contributor to pharmacy spending, contributing 53% of total pharmacy spending in 2020. And I did read someplace else that it's only about 2 to 3% of actual prescriptions are specialty pharmacy, but they're
Major part.
50% or more of the spend.
They're
So I-
they're very much the highest driver in drug spending right now.
But most of that's happening inside, if I understand it correctly, is happening not at the community pharmacy, but happening in hospitals and physician offices.
That is correct, because most, and it's not to say that independent pharmacies are incapable of providing specialty pharmacy services, but because these are very expensive drugs, because these are often drugs that include additional FDA safety requirements called risk evaluation and mitigation strategies, or REMS, that require sort of after approval reporting, so reporting on adverse events, effectiveness, things of that nature. These are services that, you know, it's hard for a smaller independent entity to provide, you know, in most cases, because the complexity of the services required to both maintain and dispense the drug, frankly, require a lot of capital and a lot of scale to make it, you know, functional. So I will say there are independent specialty pharmacies, and depending on the type of drug and the particular drug in question, manufacturers will sometimes enter into exclusivity for distribution. So they will pick one specialty pharmacy and say that everyone has to acquire it through that specialty pharmacy. So, you know, for example, if one vertically integrated, you know, insurer, PBM, you know, specialty pharmacy or retail pharmacy has to, you know, dispense a drug to a patient that is not dispensed by their specialty pharmacy, but by a competitor, they have to go through that competitor. So, you know, it sometimes, you know, they get the benefit of that exclusivity, sometimes they don't. But again, that's up to the manufacturer, and that's usually based on clinical considerations. But again, there are independent specialty pharmacies, and they are usually not excluded. They're usually included in networks for plans, because it benefits everyone to have as much access as possible if they're willing to compete on cost.
Thank you.
Mhm.
Are there any other questions from Senator Rosenwald?
No.
I see Senator Sherman on the phone as well. Do you have any questions? And then, while waiting for Senator Sherman, Representative Marsh, do you have any questions?
I'm good. It's a lot to digest. I hope we get a copy of this report.
Okay, thank you.
I think the slides themselves are on the your board website. Yeah, and I'm happy to send those to anybody who would like that as well.
Thank you. And also talking about the board's website, we've had a slight modification of the website. So if I don't have any more questions, Senator Jill, thank you for the lightning presentation today and the slides and so forth. And also, like Representative Marsh said, there's a lot to digest here. So
No doubt. I appreciate your time, and thank you for this opportunity. And please let Heidi or myself know if you have follow-up questions. We're more than happy to help in any way we can.
thank you, sir.
Thank you very much.
Okay, in regards to the website, do you want to give us a quick update on the website, what's happening with it, or
It's just a
under?
brand new website, and I welcome any feedback if anybody wants to email me or give me a call, and it's a work in progress.
Work in progress, okay. We don't have a need to meet in the, with the AG's office, so we'll move out that part. I'd like to open it up to public comments, both the ones here physically as well as those who are on the Zoom. Is there any comments from the public? If you want to make a comment from the public, please raise your hand. I think everybody's gone. All right. A note that we're going to meet again on July 25th from 10 until 12. And with that, I'll make an
I'll probably
Debatable
be
motion.
virtual,
virtual.
if I'm even needed.
Thank you for that. With that, I'll take a undebatable motion to adjourn. Thank you.
Thank you.